اوكي
شغال معك.
اوكي
الرابط على التليجرام، ما احنا حاطين الرابط على التليجرام يا شباب. احمد، الرابط اللي انا started the clinical pharmacology and toxicology, and we say before this pharmacology and toxicology is very important topic in the exam. There is no exam without pharmacology and toxicology, and I'm sorry, you should be ready at least in the exam, the first part, at least 10 questions, and mostly it is simple question, just the drug action, drug to drug interaction, mechanism of action, side effect, common interaction or side effect of the drug. Here in this chapter, we need to know some definitions, some important definitions, like, for example, the pharmacokinetic. What's the pharmacokinetic? What's the pharmacodynamic? Pharmacokinetic is the effect of the body on the drug. How the body reacts to the drug. The other one, the pharmacodynamic. The pharmacodynamic is the effect of the drug on the body. How the drug affects our body. So this is two definitions. The other one, the absorption. We said before, the absorption depends on the formulation of the drug. It is a different from drug to drug. It means what? The drug, if you have a drug, IV dose or IV medication, liquid or intravenous, this medication, of course, the action will be fast, absorption will be fast, and you will suspect the action will be fast and more fast. And the dose also, most of the time, it will be more accurate. But the solid formulation, like tablet or liquid or suspension, it will take a time to work. And it has another factor it will affect, like the pH of the stomach, the alkalinity of the gastrointestinal tract. So it has another factor will affect this one. The other definition, important definition, is what is zero kinetic and what is first order kinetic. Zero kinetic, it means a constant rate of the absorption independent of the amount left in the stomach. As I mean before, the drug is absorbed in a fixed rate, and it has no relation with the amount left in the stomach. For example, if you take a drug, and this drug is like 20 milligram, and it is in the stomach, and the zero kinetic means the drug is absorbed 2 milligram from the stomach per hour. For example, this is just example to make it easy for our colleagues. This is zero kinetic, means constant absorption of the drug irrelevant of the amount in the stomach. This is zero order kinetic. First order kinetic, it means constant fractional rate of absorption, yani percentage. So the absorption decrease with the time, and it become, the curve will go down. The first one, it's steady. Second one, no. For example, if you have 20 milligram of the medication in your stomach, and the absorption is 50%, and 50% absorption. So in the first hour, you will absorb 50% of the drug. So means you will absorb 10 milligram out of the 20. Second hour, 50%. You have in the stomach now 10 milligram. You will absorb 50%, means 5. So if you look to this one, zero order kinetic means steady. Absorption is steady. First order kinetic means steady in the percentage, but not in the amount. Percentage like 50% or 20%, but means the amount of the drug absorbed, it will be gradually decrease with the time, or increase with the time if you are increasing the dose. So both direction can happen. Next topic is ionization. I'm sorry, just to remind the people who are studying from MRCPCH clinical pharmacology, this is the essential revision notes. Ionization, it means there is some constant, pKa small. What is this constant? This constant is important to detect or to inform you about the condition of the drug. And I think, I'm not sure, it has a like fractional number like 3.7, 3.8. This is the drugs below this number. I'm not sure about this number. I need to review. The drugs less this number who has pKa less than this number, it is highly soluble and the drug absorption from the stomach will be fast. But the other drug who has more than this number, this is what I noticed from my reading. The drugs who has a number bit bigger than this number, it will be absorbed in a slow rate. For example, go see an example of this one here: aspirin and the phenoxymethylpenicillin. And the penicillin, it will be absorbed fast from the stomach in acid media. Okay, but another drug like phenobarbital, it will be the absorption in this one is not so good. So the absorption will be little in the acidic media, and the phenobarbital will be absorbed more better in the alkaline media. Okay, this is the ionization. So it will help and inform you about the nature of the drug. It will be absorbed well or not absorbed well. Some drugs, as we give an example now, phenobarbital, it will be absorbed well in alkalitic media, and aspirin and the penicillin will be absorbed well in acidic media. For this reason, if you look, for example, we have a neonate. We don't like to use penicillin as oral and aspirin as oral in neonate. Why? Because the stomach of the baby is secreting acid in a less amount. This means that the absorption of this drug is not so well in the baby. It will harm the baby only, and it will not give so highly benefit for this baby. So if you know this, the ionization of the drug, it will help you too much. Of course, it will help. The other one, go in the neonate and see here what he is mentioning about the neonate. At birth, the drug with the acidic pKa or ionization will have decreased absorption, and we say that before. So in the first 24 hours to 48 hours of the baby life, you don't think all the medication you give to the baby, it will be absorbed as the adult or the children or the infant. Yes, it will be absorbed, but the percentage will be affected, and it will be late, and it will be taking more time. This is one reason. The other reason also in the neonate and in the young newborn, and this one it will go also with the preterm baby. Preterm baby, the gastric acidity, it will be less. HCl in these babies will be less. Motility of the intestine and the stomach will be less. So of course, the absorption in this case, mostly it will be low. We should, as a physician, take care of this point, and we should notice this one very important point. The second, if we go to the second point, absorption and pKa of some drugs in comparison with the adult and the neonate and pediatrics. If he give you in this table some drugs to know the difference between the pKa in some medication, and he make a comparison between the children and neonate and the adult. Look, for example, the first one, the ampicillin. His pKa is 2.7. I told you there is a number. I'm not sure about this number. This number looks around 3.7 to 4. Any drug who has pKa less than this number, you will have a good absorption capacity from the stomach, from our GI system. Ampicillin and penicillin has a good absorption capacity. Look to this number, pKa. But go to phenytoin, go to paracetamol, the absorption is very bad, not good. Because of that, we don't like to give this medication as an oral form. And if you need to give to some patient as oral form, mostly you will give a high dose to give the effect. And this is very important point also. And very clear, we notice this as practical. Phenytoin, if you give to some patient phenytoin, most of the time, you will look the dose is high in comparison to other anticonvulsant drug. Why? Because the pKa of this drug is high, 8.3. 9.9 in paracetamol, so you need to give higher dose in this case. But look to another drug like diazepam. Diazepam, it doesn't matter. It doesn't have a big difference between the newborn and adult and the children. Why? Because his pKa is around 3.7 to 3.8. This one, it will give the same effect nearly. Now we will go to another way. Now we speak about the effect of the medication in the neonate and the oral form of the medication. Second one is the rectal route. When you are giving rectal route medication, of course, some medication we need to give it rectal sometime. Why? For example, if you have a baby and you cannot have access, IV access, and you need to give like some drug like paracetamol, like diazepam, like, yeah, you have another route to give. You can give diazepam via rectal. You can give it, sometime we give it nasal, by the nasal mucosa, and the effect is good. And we saw it by ourselves. So we have another alternative way. This another alternative way is the rectal route. The rectal route, it has a benefit. Why? The absorption capacity in this one is good. So the rectal way, it's good in some drug, not of course all the drug. And we have one important point, and this medication should stay. If you are giving medication to a child, to a newborn, you should be sure this baby will not defecate and pass stool fast. If he passes, he's not gaining benefit. And of course, in the adult, it's easy to tell them, try to control yourself not to pass stool. So mostly the rectal route is a good route and another alternative route for us. Another one, and this sometimes we miss it as a pediatrician even, the topical route. The drugs we are giving through the skin. This is very important. Some of the people, they think it's the same, just that the skin is absorbing in the same rate in adult and the children and the newborn. I'm sorry, it's not the same. There is a big difference. The newborn baby has a big difference from the other human population in some way, in different issues regarding to his skin. First point, his skin is different from the adult. The skin of the is even the preterm is worse more. The skin is highly fragile skin, so it can absorb very fast in comparison to the skin of the adult. So this is one point. So if I am giving, for example, fusidine or dexamethasone to the newborn baby, of course I should adjust the dose because it will harm the baby. The dose not like the adult dose, and the concentration not like the adult concentration. The second point, the hydration of the baby skin. The baby skin is not like us. Our skin is more or less dry. But if you go to the baby, you will see the skin of the baby is more hydrated. So the absorption capacity for the newborn baby skin is more. So if you give the same, for example, you are giving dexamethasone to the baby, steroid through the skin, no, the effect will be high. And most probably, if you give this one, you will have maybe another problem to the pituitary or the adrenal gland because you are giving high dose. Sometimes it will be toxic dose and you didn't notice. So this is important. So the first one is the immaturity of the skin of the baby. The second one, the hydration state of the baby. The third point also is the surface area of the baby. The newborn baby surface area, it's different from the adult or the children or pediatric age group, because the surface area for the newborn baby, it's high in comparison to his body mass. This is important. So if you compare me as an adult, my skin area compared to the newborn area, surface area, there is a big difference. So we should notice this one during giving topical medication. So in the newborn, the absorption capacity is high. Okay, so this is very important point. Also, you should have a good care if you are giving, for example, and this now we start to minimize this attitude. If you are giving, cleaning the skin of the baby, you insert a line, central line, you will give a cannula like this. Before we are using iodine, the iodine. This now we try to minimize too much as we can. Iodine we don't like now to use. We are using chlorhexidine, and don't use with high concentration, and don't keep it for a long time on the baby's skin because you are harming the baby. You didn't notice you are harming. The absorption capacity of the skin of the newborn is very high in comparison to children or in comparison to adult population. The other route in the children and the newborn is the intramuscular. Intramuscular route is not preferred because of a lot of issues. We don't like the intramuscular. First of all, the small the small muscle bulk in the newborn is small in comparison to the other population. This is important because of the small muscle bulk where you will give. This is one point. The other point is the perfusion and the muscles of the baby. So the absorptive capacity in the muscle, it will not be good for the baby. But first of all, the small muscle mass in the newborn baby. The second point is the absorption capacity of the muscles of the baby is small in comparison to the other routes like IV or oral or this. So it's not preferred route to give IM. For myself also, there is a danger because the muscle bulk is small in the newborn baby. So it's liable to make, in some babies, if you give a wrong IM injection and the buttocks like this, you may harm the sciatic nerve. And this is very dangerous also. So only allowed to give in the anterior of the thigh of the newborn babies, not to give on the buttock. So the intramuscular use in the newborn and in the infant, we don't like, and it's rarely used in the newborn. The other topic is the distribution of the drug. Most of the drugs used is water soluble. Most of the drug we are using, mostly it's water soluble. So it means it will go easily to the kidney and the liver, and it will distribute fast to all the body organs, including the GI system, the heart, like this. So the distribution in the newborn also is high. Why it's high? Because the newborn baby, if you compare the body of the newborn and body mass, and in the newborn, the baby has a big amount of the water in comparison to the adult. Most of the newborn baby, his water content is more than the other compartment. So means if I give the same dose in the infant or the newborn or the child or adult, no. It will be very difficult for the baby, because at that time you are making toxicity to the baby because of the higher amount of the water. And as we say, most of the drugs is water soluble. So it will distribute it very fast. And the baby, it will go to the liver, the lung, the heart, to the brain, there, very, very fast. And it will harm the baby because of his amount of water in comparison to the other. And if you compare this one by milligram per kg, for example, if we wrote, for example, fixed dose for some medication, and you come and divided it in comparison to the body weight for the baby by kilogram, you will find your dose in the baby is very toxic to these babies. There is another important point also, I think I mentioned it before, is some drugs is bounded to the distribution by the protein binding capacity. We have this topic before, and I think I cleared it before, maybe in the neonatology. We have some like the bilirubin mostly carried by the albumin. If you give by wrong high dose of, we don't like to give sulfa or sulfamycexazole to the newborn baby, because one of the major side effects of this one, it will compete with the bilirubin for the albumin, and then it will separate the albumin from the bilirubin. Then the bilirubin will be high level and it will be toxic level, and this one, it can create kernicterus, because you are giving some medication which you should not use for the newborn. So he will give you example here by the phenytoin. Phenytoin is highly protein bounded, but as there is less protein binding in the neonate, means this one low plasma protein level and low binding capacity. So there is more free phenytoin than in the other older children and adults. So in the neonate, the phenytoin is highly to be free, too much. Thus, the therapeutic range of the phenytoin, this is important point, the therapeutic range for some medication is very narrow. If you compare here the therapeutic range in unit of the phenytoin, it's 6 to 15 milligram. But the same medication, the therapeutic range for the children and adult is 10 to 20. Why this happened? It's the same medication, but why this medication? He has a different therapeutic range between a newborn and adult because of the binding capacity to the protein, or protein binding capacity, which we say this is affected by the age and the amount of the albumin and the protein available in the body. We say in the newborn babies and the children and infant mostly, the amount of the protein and the amount of the albumin is less, so the binding capacity of the phenytoin to the albumin is less, so the therapeutic range will be less and narrow, and this makes it difficult to adjust the therapeutic dose. This is one of the drugs, the phenytoin. We have some drugs we need to do level for these drugs. One of them is the phenytoin. Why? Because it's easy to be a toxic level, and if you reach to the toxic level, you will harm the baby. If you have a bigger dose in the body and it's not needed, already the drug reach to the therapeutic level, and still you are giving the medication. What you think? Already khalas, all the receptors for the medication is full, is satisfied. Whatever you give the medication, the response will be toxic. Just only you are creating toxicity to the baby. So we have some drugs we should do level for them. One of them is the phenytoin, phenobarbital, and aminoglycoside, of course, aminoglycoside including the amikacin, gentamicin, and vancomycin. These 5 drugs, it came always in the exam. These 5 drugs, phenytoin, phenobarbital, aminoglycoside, amikacin, gentamicin, vancomycin. He will ask you about the level and toxicity of these 5 drugs. It's important to know this one, and we will come to this topic afterward, inshallah. The second point is the reduced protein binding is the result of. He explained to you here why there is some drugs who has a reduced protein binding. He gave you 3 reasons for this one. First one, low level of the plasma protein, particularly the albumin. This is very important for us. Is it pathological? No, this is the normal physiology in the newborn. Most of the newborn, when he will deliver and you check the albumin, you will see the albumin, it's low, especially if this newborn is extreme preterm babies or admitted in an ICU, and you have a lot of investigation to do, and the liver, of course, is immature. So the liver function already is not well. And this is the reason why these babies has most of the time low albumin. If you have this low albumin, you will have trouble with some medication. One of them here, as we mentioned, is the phenytoin. And the toxicity to bilirubin also, it will be high. So this is the reason, if you go to the photo chart, you will see most of the time we are using low parameter in comparison to the term babies for the phototherapy. If you see the level in the preterm babies, you'll see our level is very low level. If you compare it to the term babies. أهلين حبيبي أحمد.
سوري راح ينقطع البث.
نعم تفضل.
خلينا نقطع هسه ونرجع بعدين.
أوكي حبيبي أفصل.
Okay.
Sorry, our colleagues will